I'd like to welcome you all. I'm your moderator, Ron O'Donnell, a clinical professor and psychologist at Arizona State University's College of Health Solutions. I'm the faculty in the Doctor of Behavioral Health degree program focused on integrated healthcare, the team-based coordinated treatment of physical and mental health problems using behavioral interventions, ideally in the primary care setting. My current focus is on global integrated healthcare, conducting research and workforce training in Southeast and South Asia, and more recently, Africa. I'd like to thank you for joining our Health Talks webinar brought to you by the College of Health Solutions at Arizona State University. Our college works to address the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These Health Talks are one way we serve the community with timely and relevant educational information that also provides continuing education credits at no cost. Before we begin, a few quick housekeeping items. First, this session is being recorded and will be posted on our website, asuhealthtalks.com. After the panelists' presentations, I'll moderate a Q&A session. We'll have about 20 minutes for question and answer. Please submit your questions using Zoom's Q&A feature, not the chat box. That's appreciated. Whether you have requested seat use or not, please register your attendance using the self-check-in box posted in the chat. We have an accurate record of who attended today's webinar. Finally, you'll receive a brief survey asking for your input about today's webinar. If you're requesting continuing education credits, this must be completed to receive credit. If you didn't apply for seat use, we'd still appreciate your feedback to improve our series. I'm so excited to introduce today's speakers. First is Dr. Gregory Meyer. I'd like to welcome you all. I'm your moderator, Ron O'Donnell, a clinical professor and psychologist at Arizona State University's College of Health Solutions. I'm the faculty in the Doctor of Behavioral Health degree program focused on integrated healthcare, the team-based coordinated treatment of physical and mental health problems using behavioral interventions, ideally in the primary care setting. My current focus is on global integrated healthcare, conducting research and workforce training in Southeast and South Asia, and more recently, Africa. I'd like to thank you for joining our Health Talks webinar brought to you by the College of Health Solutions at Arizona State University. Our college works to address the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These Health Talks are one way we serve the community with timely and relevant educational information that also provides continuing education credits at no cost. Before we begin, a few quick housekeeping items. First, this session is being recorded and will be posted on our website, asuhealthtalks.com. After the panelists' presentations, I'll moderate a Q&A session. We'll have about 20 minutes for question and answer. Please submit your questions using Zoom's Q&A feature, not the chat box. That's appreciated. Whether you have requested seat use or not, please register your attendance using the self-check-in box posted in the chat. We have an accurate record of who attended today's webinar. Finally, you'll receive a brief survey asking for your input about today's webinar. If you're requesting continuing education credits, this must be completed to receive credit. If you didn't apply for seat use, we'd still appreciate your feedback to improve our series. I'm so excited to introduce today's speakers. First is Dr. Gregory Meyer. Dr. Meyer is a professor of practice with the College of Health Solutions at ASU. His research interests include hospice and palliative care and chronic disease management. He holds an MBA from ASU Thunderbird School of Global Management, an MD from Tulane University, and completed his residency in general surgery at Mayo Clinic Graduate School of Medicine. Dr. Meyer will be followed by Dr. Billy Weingard. Dr. Weingard is a graduate of the University of Arizona College of Medicine, where she discovered her love in caring for and finding connection with kids and their families. She completed a pediatric residency at Phoenix Children's Hospital, Maricopa Medical Center in 2015, and a fellowship in pediatric hospice and palliative care medicine from Nemours Children's Hospital in 2016. Billy currently serves as attending physician at Phoenix Children's Hospital and as pediatric physician for Hospice of Valley. In these roles, she worked closely with interdisciplinary teams as the physician lead for the perinatal palliative care programs for both organizations. We're so fortunate to have these experts today with us as we explore compassionate journeys, hospice and palliative care, for the ages. Palliative care offers comfort, care, and aims to improve the quality of life for those suffering from a serious ailment, while hospice care provides that support specifically in the final weeks or months of life. Emotional challenges surrounding illness and death can affect uptake on hospice and palliative care, but both types of care provide crucial support for patients of all ages and their families. They will learn about the unique needs and challenges of different age groups, help deliver patient-centered, empathic hospice and palliative care during life's most challenging moments. Whether you're a caregiver, healthcare provider, or family member, this webinar will offer valuable guidance on approaches that ensure comfort, dignity, and quality of life for everyone in need of care. Our first presenter, Dr. Gregory Meyer, with an overview of palliative care. That was the stage for Dr. Weingard's presentation next on pediatric and palliative care. Thank you, Dr. Meyer.
Hey, can you see that?
Yes.
Yes.
Okay, good. All right. Well, we were playing around at the last minute here, so I'm glad that the technology is agreeable today. So thank you, Dr. O'Donnell. And again, it's always nice to see Dr. Weingard. We've known each other for years and worked together. And so I'm just going to give a short overview of palliative care. I'm sure some of you are more knowledgeable than others about palliative care. I've been involved about 20 some years, and also with hospice. So just think of palliative care as a program of delivering care that deals with severe and complex illness. This is the definition that frequently is shown in association with palliative care from the World Health Organization. And as you can see, it defines palliative care as an approach that improves quality of life of patients and their families facing problems associated with life-threatening illness. It's patients and their families are all cared for together, since many of the problems with the individual patient affect the family. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other physical, psychosocial, and spiritual problems. As in the definition, think of it as specialized, deals with various areas of issues. It's of any age. Dr. Weingard will talk about her experience and her work with perinatal and pediatric palliative care. So any age and someone with a life-limiting illness. It's team-based, also like hospice, holistic, and it involves, as I said earlier, the patient and the family. It can be provided anywhere, wherever home is, pretty much. In the hospital, outpatient clinics are a very important resource to have for patients to go to instead of the emergency room if they're a palliative care patient and they start to have issues. Skilled nursing facility, again, wherever home is, the palliative care goes to. A big difference between palliative care and hospice is individuals receiving palliative care continue their curative treatments, which is different than hospice. But hospice, again, is later in the disease process. So with palliative care, they're able to continue and stay involved with whatever type of curative treatment they're involved with. One of its very important roles is collaboration. It supports and collaborates with all of the healthcare providers that individuals had, specialists, general practitioners, social workers, whoever's involved. Palliative care team will coordinate and collaborate with those individuals, kind of like the quarterback is, making sure that those are all services that are continued when appropriate and connected and communicating with each other. And frequently it is confused with hospice. I've had many times to go in on a consultation and introduce myself as a palliative care physician, and sometimes the first response is, well, I'm not dying, I don't need hospice. So again, it is confused. And it's sometimes part of the explanation when you first have a contact with an individual about the differences between palliative care and hospice. And at the bottom, I included the quadruple aim, focused on patient experience, population health, cost of care, and the provider experience. It started out, it's evolved over the years from the originally a hospice was the type of care program for people at the end of their lives, towards the end of their lives. Hospice came to the United States in the early 70s, and the first actual, quote, palliative care program or unit was started in Montreal. Dr. Declan Welch, whom I'm sure some of us have met and interacted with at the Cleveland Clinic, he was the one who first in the late 80s started the first palliative inpatient care program. And then soon after that initial program, there was a fellowship that evolved, and fellowships are very common now across the country and internationally. And palliative care became a board certified specialty in 2006. So again, a progression. And just think again, the current paradigm is chronic disease management. Straightforward slide showing how people will progress from a healthy situation to a phase 2 where they're starting to have chronic illness, and that chronic illness or illnesses will progress. And then towards the end of that disease process, they'll be in a more of a functional decline and their needs increase over time. This slide shows, again, that progression, how early diagnosis and treatment, usually there's just the physician, the primary care physician, the specialist, and then as a disease, say, think of heart disease, respiratory disease are common ones, that those progress over time. And at a period of time when it's really starting to get worse, palliative care will be involved. Initially, it was always in a hospital-based service, but now, as the previous slide showed, it's home-based, inpatient, outpatient. And then over time with a disease, say again, like cardiac disease, there'll be a time that the palliative care team will kind of transition, and the individual will go to hospice care. But think of it as all one continuum. And because whether it's hospice or palliative care, it's all palliative care. And then, of course, at the end, there's the death, where services for grief and bereavement support are provided. So again, that transition over time. This just shows, why is it important? Well, we're all living longer, older, and all of the treatments, the medications and things, we're able to live longer and a higher quality of life with chronic illnesses. And part of that progression is, again, helping to care for the individual, collaborate with other physicians. So again, we're living longer, and more of us will have palliative care needs. 50 years ago, things were much different than they are today. You had a severe disease such as cancer, cardiovascular disease, and your prognosis and your options were over a much shorter period of time and fewer in number. Treatments 50 years ago were rarely curative, and most of the time a practitioner plus or minus a specialist was involved, and most of the time the care was provided in the hospital. Nowadays, it's chronic diseases, 2 or more usually. The prognosis is much longer, extended, many more curative treatments, interventions, medications, devices allowing us to live longer with these illnesses, and the development, again, of that team-based, coordinated, holistic care that palliative care is part of. And emphasis not on inpatient care, but outpatient care. Everyone's aware of health spending, and whether it's pharmaceuticals or hospitalization or insurance. And these are the top diseases that, again, nowadays you can have 2 or more. And cardiovascular, cancer, pulmonary, you can read through them. So again, people are living with multiple chronic diseases or illnesses. And again, the need for palliative care is increasing every year. Graph that we all know about the difference in health spending based on age. 36% of individuals in that 65 plus are proportion of their spending. And again, the unequal weighting of who's utilizing healthcare, generating the spending, and you can see how it's concentrated. 24% or 1% of the people with the highest spending are using 20 or spending 25% of our total expenditure. So again, unweighted or very weighted. And again, another reason why palliative care can help those individuals with those high spending treatments and needs. Reimbursement. Quickly on palliative care, it is reimbursable. It's not something that's going to generate a new healthcare building or anything, but we are able to bill for palliative care. And that's based on 2 principles. You either bill based on the complexity of the situation you're dealing with or the time involved. So again, there's 2 ways to bill. When I was actively doing palliative care, we tended to use the time-based billing for reimbursement. But again, there's 2 options, complexity or time-based billing. Trying to meet the demand for palliative care, and as you can see in the lower left, about approximately the World Health Organization says that 14% or so of people who need or would benefit from palliative care are not receiving it. So the ways to provide it have, again, expanded over the years. Initially, it was in-hospital, consultative, but over time, it's grown to all of these different modalities. Telehealth, web, or Zoom visits are very common now, especially during COVID, and that has continued. And again, you'll see the different ways that we're trying to meet the demand for palliative care. Another important role for palliative care is helping individuals with chronic illnesses stay out of the emergency room. Are there ways to deal with those situations in the home before someone goes to the emergency room? And again, another reason that a palliative care clinic is so important, where you can have individuals that are being cared for by a palliative care team. They can go to the palliative care outpatient clinic, be treated there, and again, avoid all of the negative issues that can occur in an emergency room. And you'll see how it's weighted as people get closer to the end of their life, what percent of them will go to an emergency room. Last month, about 50% will visit the emergency room. So again, if you could find a program or a care model that helps decrease that number and deal with these situations that, again, as it says on that 3rd bullet, that could be preventable or treated for or managed at home, all the better for everyone, because it's such a huge dissatisfaction for individuals and families that use the emergency room and the providers, et cetera. So again, how do we deal with helping that stream of individuals going to the emergency room, care for them better, and deal with their situation? Just a slide that shows societies. American Academy of Hospice and Palliative Medicine is the largest organization in the United States, but palliative care is all over the world. Good friend and colleague of mine is involved in palliative care for the South Island in New Zealand. So it's all over the world and growing every year. And again, one last slide. Many times in a situation in the hospital, the emergency room, in an office, it's there to talk about, but it's not discussed with patients and family, palliative care and what it can do. So I think we're doing better with that and addressing it more often, but still there's many times where it's something that should be brought up, but is not brought up. And everyone likes to roll around in the snow, so I will pass it over to Dr. Weingart now.
Thank you so much, Dr. Meyer.
Dr. Weingart, thank you very much for your next presentation. Please go ahead, but a quick reminder, first of all, if you haven't already done so, please register your attendance using the check-in link posted in chat so we can have a record of who attended today's webinar. And again, use the Q&A for any questions for Dr. Meyer or Dr. Weingart. Thank you. Dr. Weingart?
Well, thank you so much, Dr. O'Donnell, the College of Health Solutions. I'm just so honored to have been invited to be a part of this. So let's see, just going through. I don't have any financial interests or anything else to disclose. I think it comes up a lot when I introduce myself as a pediatric palliative care doctor. People sometimes get a confused look on their face and say, "What do you mean, kids?" Recently I was part of a medical student event at Phoenix Children's where some medical students came and they came to my session and they said, "Well, we didn't know that palliative care for kids was a thing." So again, giving us this opportunity to share what we do. Because unfortunately, taking care of kids is about more than superheroes and puppies. With that, I would just like to offer this disclaimer. Kids are not supposed to die. Babies are not supposed to die. They're not supposed to be sick. And so thinking about them having a potential life-limiting condition is very difficult. So I will offer you this quote from one of my most favorite books. If you have not read it, I would encourage you to. I think it's one of those that can truly change the way that you think and the way that you live your life almost. The quote, "Sometimes we can offer a cure, sometimes only a salve, sometimes not even that. But whatever we can offer, our interventions and the risks and sacrifices they entail are justified only if they serve the larger aims of a person's life. When we forget that, the suffering we inflict can be barbaric. When we remember it, the good we can do, or the good we do can be breathtaking." So just keep that in mind as we go through this information. So what are pediatric palliative and hospice care? The same as what Dr. Meyer had shared, it is really a philosophy of care that really looks at care and are we matching what's most important to kids and their families with the care that we're offering and providing. Okay. Why should we care? Well, there are 60 to 70,000 kids who die every year in the United States. There are 3 million of the 76 million children living in the United States with medical complexity, chronic life-limiting and life-threatening conditions. With medical advances, as with adults, kids' conditions that used to be fatal are now chronic. But with that comes the addition of asking families to make more and more decisions. Do we have this surgery? Is this living on this type of support a quality of life that we find acceptable? The number of those kids living with these illnesses is increasing every year. care is becoming more and more complicated. It's really becoming where a lot of families that we meet, maybe one parent is having to make a decision to give up their careers to stay at home and take care of their kids because of the level of complexity. Or, some families even make the decision that maybe their children should live in a group home or outside of the home because that's where they're going to be able to get the best care. The death rate is a little higher, but it's slightly decreasing. And it's estimated that there are 5,000 children with complex chronic conditions in the last 6 months of their lives on any given day. And at least 8,600 kids eligible for palliative care. Okay. Bringing it to babies. So in the United States, more than 20,000 infants die every year. Infants less than 1 year old have the highest mortality rate in pediatrics. I know when I read that statistic, I was a little bit dumbfounded and confused, but it makes sense because most of the babies that do pass, they're passing from congenital malformations or chromosomal abnormalities. So just conditions that we are not able to cure or to fix. 1 in every 33 babies is born with at least one birth defect. So that's 120,000 babies every year. And now with our prenatal screening techniques, many of these conditions can be identified. So I always like to think about things in kind of analogies or with numbers. So at the bottom of the screen, you can see, so a Boeing 757 seats 224 people. So the number of babies born with at least one defect every year would fill 536 of these planes. So it's not uncommon. And then just another keeping with the plane analogy. So there are 237,000 children in the United States who live with life-limiting conditions. So again, that's the equivalent of 570 of these Boeing 747s. And then there are somewhere between 11 and 14,000 kids who die every year. So that's the equivalent of 26 to 33 of these planes crashing with no survivors every year. And that's one plane every 11 to 14 days. And these kids really deserve somebody to be an advocate for them and their families and talk about what's most important as they navigate this journey. So these are just the causes of death through over time. You can see for infants, their cause of death is related to cardiovascular malformations, congenital conditions, genetic conditions, whereas in children, it shifts to being more accidents or suicides, things that maybe you can't prevent, but still will have sequelae for these kids and their families. Okay, so pediatric palliative care, the same as adult palliative care. It's delivered by an interdisciplinary team. I will say our team has a few extra members. We love our child life specialists. We love our bereavement counselors. We just want to get everyone in there to support not just the child, but their family as well. It does include symptom management and psychosocial care, spiritual care. It really is family-centered, again, bringing it back to the family and what's most important. We want to assess, what kinds of burdens is this medical journey causing? And is that burden still greater than, or the burden less than the benefit that we're receiving from that therapy? And I will say, I think it's changing for adults, but a lot of families that I meet, I talk about that, our adult counterparts wish that they could practice the way that we do because we really get to meet families much earlier in the disease trajectory and support them. In my work, I'm meeting many, many families before a baby is even born with a potential life-limiting condition, so that we can talk with them, talk with the parents about what's most important to them. But there are big differences. So Dr. Meyer had talked about hospice care being exclusively for that end of life, and when families are ready to forego more disease-directed or life-prolonging interventions. With the passage of the Affordable Care Act, kids who receive health insurance through Medicaid or through the CHIP program actually are eligible for concurrent care. So they can have their hospice support in addition to continuing some of these disease-directed or life-prolonging therapies. This becomes especially important for kids who are dependent on medical technology, because before parents were facing that decision of giving up the support and the care that they needed for their child, BiPAP, home ventilator, home nursing, and most families would not give that up. And so we're not able to take advantage of the support that hospice can provide. The effects of development on understanding and participation. Yes, we have kids that are included in some of these conversations, depending on their developmental stage, their maturity, their desire to be a part of these conversations. Because they really understand what is going on in their body and what this disease means for them. We have such rare conditions, and none of the kids read the books that we, have that says this is what your disease is going to look like. I tell a lot of families, I don't say, what their journey is going to look like, because inevitably that child's going to come back and say, you're not the boss of me, and I get to, this is my journey, not what you say it's going to be. In pediatrics, we have surrogate decision makers. So kids have not reached that legal majority where they can make their own decisions. So we're asking their parents to make decisions for them. We have siblings that we have to take into account because they are also walking this journey. There are ethical concerns. Again, children are a protected population, so a lot of differences in that. And then there's the hope aspect. Again, kids are not supposed to die. And so when we get to that place of talking about end of life, it feels very unnatural. But palliative care, so one of the most rewarding, the best parts of my job is really supporting parents in their decision making, getting to know them, getting to know their kids, hearing about what's most important to them, hearing about the things that they're hoping for or the things they're worried about, how they define a good quality of life or how they define suffering, and really letting those goals and those values direct care. So rather than just presenting them with a menu of different options that they can choose, really getting to know them, hearing about what's most important, and then helping to direct in those things that we can do. I feel like outside of palliative care, a lot of times folks will not necessarily lean into the complexity of parental decision making. We often present it as, well, these are the things we can do. This one they might live, but then they're going to have this. This one they might live, but then they might have this, or, without this, they're going to die. Parents' decision making is much more complex than that. They want to know, is my baby going to have a good life? Will my baby be happy? It's not infrequent that I hear parents say, I just don't want my baby to resent the decisions that I am making for them later on. And then it also involves, will their family be happy? How will their family navigate this journey? I think one of the big scaries about palliative care or introducing palliative care is, well, then the family is going to say that I gave up hope. And that is not our purpose at all. um, from the palliative care literature, hope is a positive expectation that goes beyond visible facts. It's a concept greater than mere expectation. It's an active process of conscious and unconscious meaning. It's a motivating force, and inner readiness to reach goals. It actually will help in finding meaning in life. It's a reflection of what's most important to that person, to that family. It's a way to endure and to cope with suffering, and actually a way of supporting decision making. Okay. One parent told me my job was to have hope and to be a positive influence. And again, we don't ever want to take that away, but maybe we're shifting what those hopes are, especially as a child's condition changes over time. And just ending, I think this quote from Cicely Saunders, how people die remains in the memories of those who live on. And this, when I was in Illinois, medical students would rotate with me, and we had a visit with a family. And afterwards, I asked that student, well, what did you think? And he said, well, that took a long time. It wasn't efficient, but it felt like caring. And that's exactly why I will tell everyone who listens that I have the best job in medicine, because my job is really just to care.
Dr. Weingart, thank you very much. Dr. Meyer, thank you also. There are a few questions I'll review with each of you now in the Q&A. First, a question from Elena. What do you do if a child does not want to make the decision but is developmentally appropriate to be included?
That's one of those tough situations. I think, we do give the child the ability to really kind of decide what conversations they want to be a part of and what conversations they don't want to be a part of, and how they want to get that information. Sometimes the child wants to hear it directly from the doctor. Sometimes the child wants to hear it from their parents. But I think when they tell us, I don't want to know, then I think that deserves some exploration as to why, or what are you thinking? What are you worried about? Um, and most of the time, the child already has an idea or a really good understanding of what's going on. But maybe they're trying to protect their parents, or maybe they're trying to protect their siblings. And so I think leaning into that, and also leaning on our child life specialists and our psychologists to really help understand. Um, and then there are some times where you don't have a choice, that we really have to disclose some important information or serious information to them. And again, doing that in a way where they feel safe, and that aligns closest to what they or how they want to receive that information.
And that also works for adults too. Many times adult will not want to have that conversation. So you end up talking with a family member, etc. You prefer to talk to the individual, like Dr. Weingart said, but sometimes people don't want to have that conversation. But you still need to inform the family at least about those different options and program benefits, etc.
Thank you both. Next question is from Dylan. Is there a health disparity that affects certain communities more so than others for children with health complications or facing different social determinant of health barriers? And I'm sure that also applies to adults.
Mm-hmm. The short answer to that is yes, unfortunately. I mean, even if you look in Arizona, there are palliative care services in the greater Phoenix area, and there are a couple of pediatric palliative providers in the Tucson area. The rest of the state doesn't have ready access to the same level of care. I think telemedicine has really made a difference in the access that some of our families who are in more rural areas, so they have access, but is it the same level of care or the same level of, is our ability to provide the same level of care the same? I'm going to say no.
Thank you. Next question is related. Do children with private insurance face difficulties receiving concurrent care? You mentioned that kids with Medicaid CHIP are covered, but do you experience insurance barriers in the private insurance market?
I'm sorry, Dr. Meyer. I feel like I'm hogging all of the questions. The short answer to that is it depends. I think there are some insurance companies, when we explain, what concurrent care is, that, it is a benefit that's provided to children with Medicaid or CHIP. Sometimes they will also provide that care, but they're not required to. And so then in some circumstances, they won't. In Arizona, they're through Arizona Long-Term Care, a lot of our kids can get Medicaid as a secondary. And so then that does allow for concurrent care if the primary insurance is on board with that. Again, it takes some extra hoops and some extra work for us, but the majority of our kids are able to receive both disease-directed and hospice care.
And on the adult side, many insurance programs have really accepted the change and provided palliative care and hospice in their coverage. And again, if you think of that whole continuum of care from palliative to hospice, it just makes sense to have that benefit, and it is becoming more and more common.
Thank you. This next question is from Dr. Weingarp. I think it applies to both of you, and I had the same question. How do you remove your emotions from the care? Have you had to step back and have another doctor step in before?
Well, I am very, very lucky to work with such an amazing team of doctors, both at Phoenix Children's and through Hospice of the Valley. Yes, there are times where a family just, they set up camp in your heart and they are claiming an extra big space. I describe my heart like the Grinch, in that, with each family that I meet, it just gets bigger and bigger. But that doesn't mean that, there aren't those hard days or those families, again, where they just hit you a little bit closer. And again, I don't know that you can remove your emotions completely, but I do think like having good boundaries is important. And then again, making sure that you take care of yourselves. There are many times where, again, there's a hard situation and I'm calling up colleague XYZ and saying, hey, can we go get a coffee? Can we go? I just need to spend some time like processing this, and I need some help with that. And luckily, we have such a wonderful team that allows that.
Totally agree. I can think back 20 some 30 years and think of patients and families that they never leave you. And it's not like a negative, because I think when you end up focusing on the value you add to a situation during a very difficult time, that provides comfort for the individual provider. And as Dr. Weingart said, yeah, some hit you harder, but again, just remembering the ability to help is comforting for all of the physicians involved.
Thank you. Another question for both of you. What made you both pick a profession in palliative medicine? I have an interest in geriatric medicine and want to learn more about this specialty. Thank you.
All right, Dr. Weingart, I'll go first.
Okay.
Well, I was a general surgeon by training, and I love the experience of the operating room and the team and everything. But I found that what was going on outside of that was less fulfilling. And I ended up getting involved in hospice and palliative care as a volunteer when I was transitioning from a private practice. And I was just, I tell people it was like that puzzle piece that just fits right in there, and you feel you're in the right place at the right time and with the right team around you. And it was the best decision I ever made. And as Dr. Weingart said, you don't, when you have a team around you, you don't have to share the whole burden. You don't have to provide your own solution to what you're dealing with. You have those around you, and that's very beneficial. And also, like she said, taking care of yourself. But again, that was kind of how I evolved. And as I said, it was the best decision I ever made.
I think I kind of stumbled into it. So as a medical student, I thought that I would be an oncologist. And so actually was trying to decide between being a pediatric oncologist or an adult oncologist. And so I did an elective out at Mayo, and Dr. Finch was one of my attendings. For those of you who haven't met him, he is truly one of the most amazing physicians. You know, we would go to a patient room and he would say, okay, I'm your hematologist, and let's talk about that. And then he would say, and now I'm going to switch hats and I'm going to talk with you in this other role that I fill here at the hospital. And again, those conversations really felt like caring. And that's what I wanted to do as a doctor. I realized I didn't necessarily want to fix anybody. I didn't want to necessarily cure a condition, but I wanted to care about them. I wanted to hear about what was most important, and I just wanted to share that with them. And so from that, it was, well, this is what you're going to do now, and forget all of that cancer business.
And I will give Dr. Fitch an early Thanksgiving present by telling him those wonderful comments, Dr. Weingart.
Well,
I see
he's
him
been
on Tuesday, I think.
a big inspiration to me through my career.
The next question is from Elaine, is for Dr. Meyer, but I think it applies to both of you again. Why do you think palliative care is under-discussed? How can healthcare professionals, especially social workers, advocate for broader recognition and understanding?
Well, I think a great question. Couple of things. You know, as I said and showed in that one slide, it hasn't been around for a long time. It's evolved, and some of that is just the knowledge factor, not being aware of what it is, and a clear understanding of what it is and what it isn't. And so it's taken time, and it's definitely in a very significant growth spurt with programs. I think in the Phoenix area, there's probably 10 palliative care fellowships and more, or programs and fewer fellowships, but they're growing every day. So again, it's just something that has taken time, and even as at provider level, providers need to be educated about it. And there has been a lot of national through organizations, locally and nationally, training programs, education programs, weekend conferences about palliative care. So it's got to catch up, but it is catching up.
Mm-hmm. And I will say, so another experience talking with actually an ICU doctor. He told me, well, you just think differently than everyone else. Because again, in palliative care, we come from that place of letting the goals drive the treatment. And I feel like a lot of times in medicine, it's still about what's the next thing that I can do? What's the next thing that I can offer? What's the next treatment, the next surgery, the next, and so again, I think it's hard for people to tap the brakes and see like, oh, well, these are the things we can do, but maybe we shouldn't. And then I think, in medicine, we're humans. We fall in love with the patients and the families that we take care of. We want them to live a long, healthy life. And I think it becomes hard to recognize that maybe that's not the way that the journey is going to turn out. And so I think it's hard. I think also there is a whole lot of, well, if I refer to palliative care, then maybe they're going to think that I'm giving up hope or that I'm ready to be done. And it really, again, so it's like drops of water carving the Grand Canyon. We're making the change. We're helping people to understand we really are about living the best life that you possibly can and not about dying.
One thing I used to like to do, it may sound corny, but when I was talking initially with a family, I'd say something to the effect of, you're used in healthcare for the physician to have the baton and conducting and leading your family. In palliative care and hospice, that baton should go more to the family and following their desires, educating them. So it's different. I think that's definitely the most effective way to have that kind of team switching back and forth about who's kind of conducting.
Mm-hmm. Mm-hmm. Yeah, we may know the medicine, but the family knows the patient and themselves and what's most important. So each group needs to bring their their perspective together so that we can make those plans on how to move forward.
The next question is related. What advice would you give to a social worker who works with older adults outside of the medical setting in regards to palliative care? Anything from outreach teaching to whatever comes to your mind. So for example, are there resources people can go to online as professionals to learn about palliative care and be more informed about working with older adults?
Well, they're part of the team. All those support people, whether it's spiritual person, a social worker, counselors. Again, it gets back to that team approach. And because there are things that you need someone, as far as, say, in palliative care, looking for certain types of services, transportation, physical therapy. You need people that will kind of do their job in different areas to provide, to support the patient and family as well as possible.
Mm-hmm.
Thank you. I have a couple of questions for both of you. One, we're seeing an emergence of digital health technologies throughout healthcare impacting delivery of care. You mentioned telehealth, Dr. Weingard, but Are there anything you're seeing in terms of trends for digital health? Everything from smartphone apps to AI. I just checked my own Apple phone just now and found a half dozen apps on palliative care and hospice, some for families, some professionals. Anything you're seeing in the field, the trends in digital health for your field?
I know. Just the emerge. I think, if one good thing came from COVID, it was the emergence of telemedicine and it being more accepted. Many of the kids that we take care of, they come with accessories and lots of medical technology. I had one family that we were actually having a telemedicine visit, but they talked about the day before when they took their child into the hospital for an appointment, and it took them an hour to pack up and get everything loaded into the car to then drive to the hospital, have probably a 30-minute appointment, and then do all of that in reverse. So I think just telemedicine has been so huge for our palliative care team and just being able to reach families and have them really in the cost benefit analysis for the family. Oh, I can just log onto my computer. I don't have to do all of this. And so we're seeing like our outpatient growth is huge. And if I tell a family like, oh, I'd really like to see you back in 3 months, they say, okay, no problem. Whereas before it was probably a like, do you know what we have to go through to get to the hospital to see you? But I use plenty of the apps myself to help in the care of my patients. Like, I think it extremely helpful.
I like to think of it as the balance between pushing and pulling information. Technology allows even on every morning, individual in their home pushes something out to their team and says, I'm having slept well, didn't sleep well, pain, etc. So technology, I think, helps us to kind of have a give and take between that pushing and pulling of information for a team and an individual.
A recent question, interesting. What are the implications of the high financial cost for making decisions about the care of a loved one?
I think they're really a thing. There are some families where, perhaps I meet them in the prenatal setting, and they're thinking about, well, after this baby is born, is there a potential life prolonging path? Yes. Does it come with all kinds of burdens, including financial? Yes. Is that the reason that some families choose a more comfort-directed path? Yes. Um, it's part of the reality of the world that we live in, where families do have to consider, again, it goes beyond the well-being of perhaps just that child, but to the well-being of the entire family.
One more question. Are you able to do home visits in your role?
No.
Yeah, it's a combination. A frequent model is that initial face-to-face visit for the first consultation, meet the family, get the information, look around at the setting where they're living and see what kind of things stand out as far as needs. And then subsequent to that, so you get that assessment visit. And then after that, it's a combination of virtual, which is very, very helpful. I remember years ago telling our team, I think we should try to think about trying to get technology in the home. And we're talking 20 some years ago, and they looked at me like many times people have, you're nuts. I said, well, no, we got to be able to be there somehow when we're not physically present. So again, it's a combination and very effective.
Just one last question, and it's a good one. I recall having a feeling of whiplash between what the different attending doctors told us and what palliative care was discussed with us when my parent had a deadly disease. Better education to family members about the different roles to make a decision, whose advice to follow, and or coordination of the entire team would have been very helpful. What are your thoughts?
It's still a challenge in medicine. Again, I think it goes back to, I think everyone wants to do the very best thing for that patient and for that family. And sometimes the amount that we care clouds kind of what we see and our perception of things. They've done studies, and the longer that a doctor takes care of you, the worse their prognostication becomes, just because, again, you've set up real estate in their hearts. And so I think sometimes the palliative care doctor can come in and look at the situation with fresh eyes. And perhaps they're seeing something different than maybe that primary care team. And I think, it goes back to just being human.
Thank you both, Dr. Meyer, Dr. Weingart. Thank you for wonderful presentations. Thanks for the great questions from the audience, really penetrating questions. That's all we have time for today. If you haven't already done so, please register your attendance using the self-check-in link in the chat. We encourage you to follow the College Health Solutions on social media. Note the challenge on the screen right now so you can learn more about the opportunities for talks like this one. Our Health Talk series will continue in January 25. Details registration will be available at ASU healthtalks.com. Thank you all and have a great day. I appreciate your attendance.